Hello and welcome to part 2 of Introduction to Clinical and Therapeutic Prescribing. This is following on from the video posted earlier in the week. This session is revising second year nutrition. For those of you in clinic, it's combining nutritional biochemistry and clinical and nutritional prescribing. I'm actually quite excited because I'm teaching clinical prescribing semester 2 in a couple of weeks' time, and I really love doing that subject. As a note, there'll be more videos, seminars and webinars coming up, so please stay tuned. Follow me on Instagram and view my website for more details of upcoming events. One thing to remember is that everyone is unique. We have to think of family history, genetic polymorphisms, MTHFR, where we don't metabolize folic acid effectively, around about 30 to 60% less effective metabolism of folic acid, gender, male versus female, age, childhood versus teenage, puberty, 20-year-olds, 30-year-olds, etc., etc. Different decades require different nutrients and have different metabolism thereof. The general health status of the person, nutritional status as well. With that, of course, we always investigate and correct any nutritional deficiencies found. Think of the emotional response, inflammation, oxidative stress, which are main drivers of health and disease. Then we think of absorption, metabolism, storage and excretion of foods and nutrients and how well the body does that, as well as biochemical considerations such as liver function, kidney function, as well as pyrrole disorder. Now, one misconception, of course, with pyrrole disorder is by calling it pyroles. Pyroles are required for red blood cell production. So what we're looking at is the body's biochemical response to certain molecules that are formed. There's more information on a webinar coming up on this topic. Medications and deficiencies related to those medications, such as coenzyme Q10, and previous response and adherence to the treatment with that patient. So in clinical prescribing, I've always believed food as medicine. It's my optimum main priority with the patient, is get them eating properly, correct any nutritional deficiencies found. I also support them with herbal teas. I use a lot of therapeutic herbal teas, single and in combination. I determine long-term goals, short-term goals, what are the goals required now, what are the goals required later, and I use different phases. Phase 1, Phase 2, Phase 3, and each phase is very specific for the treatment plan that I'm putting into action, or an action plan. And this can take a bit of time, and always, we may get a huge, massive, great response in the first 2 weeks. And then from there, we need to keep the response going by sort of restudying that person and working out the specific nutritional deficiencies and what else is required, and any other excesses as well. And one way how I do that is by using a table. So I determine the functions required, the actions required, and I use the following table. And here is the table. So what you'll find at the top row, we have here the actions and functions along the top, and then nutrients going down. And the idea about the nutrients is thinking about, or putting together the mechanisms of action, the actions or functions that you want to achieve in this patient, and then list them down. And it doesn't matter what order they are in, because we're about to find out how this works. As you can see on the right hand side over here, we have total and then dosage range, and I'll explain that in a moment. So here I've selected a number of actions I want for this person. Let's just say we have a 34-year-old female presenting with metabolic syndrome and polycystic ovarian syndrome, PCOS, at the same time. So what I was thinking of for this patient to get things started was an antioxidant function, anti-inflammatory, glucose regulation, cell signaling, energy metabolism, female reproductive health, cardiovascular disease parameters such as platelet function, cholesterol, metabolism, circulation, etc. And then I just selected a handful of nutrients that I believe would be very useful for this person. And as I was saying, they don't have to be exact at this time, because I'm about to show you a way on how we can work this out. While you're watching this video, think about any other kind of functions you would do for this 34-year-old female as well, because there's a lot more to add, but these are the primary functions I'm looking at with my short-term goals today. So what I've done, to give you an example, is in the columns I've done a Y for yes and N for no. Yes is that this nutrient does cover this function or action that I'm requiring for this patient, and an N equals no. And in some cases there's a question mark, because under other mechanisms of action we could get there, but it's a little bit of a leap of faith. However, it is useful to know. So let's take zinc for an example at the top here. So we have zinc, and look at all the different functions here. Yes, it's an antioxidant, anti-inflammatory, cell membrane integrity enhancer at the same time as cell signaling. I want you to think of delta 5, delta 6 desaturase, so it enhances the omega-3 function. Energy metabolism via Krebs cycle activity and glucose metabolism, generally speaking, with glycolysis. Female reproductive health, such as metabolism of estrogen, progesterone, and testosterone. And cardiovascular disease, it does work with platelet function as well as endothelium health, so I put a question mark there for now. And as you can see, it has a total of 6. Now, if we just look at the total column for now, you can see there are a number of different numbers in this column here. 6, 7, 6, 5, 4, 6, 6, 4, 6, 1, 1. Now what we're doing here is adding up all the yeses. Now to make it easy, we look at this column here and ask ourselves, do the nutrients cover what we need for the mechanisms of action or functions for this patient? And as you can see, there's quite a few that actually are up around the 6s and 7s. But then we look at chromium over here. Now chromium is very specific for metabolic syndrome with glucose metabolism, insulin resistance, and also with PCOS as well. But as you can see, it's a 5. Now in this case, and also cholesterol metabolism too. In this case, I'm going to include it in the top because it is more of a specific for glucose regulation, which is one of the main features of metabolic syndrome. In the case of boron and silica, I threw them in as examples of nutrients that don't have a high level of usefulness in metabolic syndrome. However, boron and silica can work with neurotransmitter metabolism in a roundabout way, and particularly boron with estrogen and testosterone metabolism. So maybe, just maybe, it could be very useful in this case. But looking through it, I've picked zinc, magnesium, vitamin B6, chromium, manganese, omega-3, and always look at the EPA DHA content. I tend to go for a minimum of 300 EPA, 300 milligrams that is, and 200 milligrams of DHA per capsule. There are some formulas out there with 400 milligrams EPA, 200 milligrams DHA, and 500 milligrams EPA and 250 milligrams of DHA. And turmeric, of course, that just does everything, and garlic as well. Not as much as turmeric in this case, but it does quite a few of the actions and functions that we're looking at in this patient. And as you can see on the dosage range here, I've got a number of different dosages written down for you just as an example of where I'm thinking about for this patient, because I've looked at the literature, I've looked at our textbooks, and I've looked at the information available to me to see what kind of therapeutic dosage I need for this patient. For example, chromium, 250 micrograms 2 to 3 times a day with food. These supplements are with food for absorption capacity as well. Vitamin B3, it is an antioxidant, inflammatory, but also energy metabolism, vasodilator, circulation stimulant, and metabolizes tryptophan and serotonin. So I've got this at 200 milligrams, for example, breakfast and lunch. Taking it too late in the day, in particular with vitamin B6, may keep some people awake. So the idea is to make sure when you pick your therapeutic dosages that they are at appropriate times of the day. And as I said, most are best with food. Because, for example, zinc itself improves hydrochloric acid production, digestive enzyme, pancreatic function. Thereby, some people may get a little bit hungry and have that little bit of a churny kind of feeling in the gut. And that's because the digestive system is becoming up and running. Magnesium, it's a vasodilator. 200, 300 milligrams 2 to 3 times a day is a very good dosage, and these are elemental dosages. Vitamin B6 is very useful in female reproductive health because it aims with the metabolism of estrogen and testosterone as well. It rebalances, it modulates. And there is some cardiovascular benefits, particularly with homocysteine, but in this case I've just listed it as a no because it's not one of the parameters we looked at with this particular 34-year-old patient. If it was a 50-year-old male, for example, I'd be definitely looking at, folate, B12 and vitamin B6 for the methylation and transsulfuration pathways in regards to homocysteine metabolism in an older patient. But at this stage with this patient, she didn't have any issues with homocysteine, which is very good. Omega-3, as I was saying, anti-inflammatory pathways, pain relief. It does work with cell signaling, cell-to-cell communication, cardiovascular health, antiplatelet function, vasodilation, endothelium health as well. So this is just a bit of a snapshot I want you to look at. So following on from this table, I'm thinking of acute versus chronic prescribing. Is the condition in an acute stage right now, or is it more in a chronic state? So for example, metabolic syndrome, osteoporosis, osteoarthritis, diabetes. These are chronic diseases, but they do have acute flare-ups. So that's where dosages may change from twice a day to 3 or 4 times a day. And then at the same time, I'm reviewing their diet, going through their lifestyle factors and working out whether this is a clinical deficiency or a subclinical deficiency. So a clinical deficiency, for example, could be scurvy, and a subclinical deficiency could be similar, where it's got lowered immunity, bleeding nose without digging for gold, easy bruising, weak capillaries, and just more frequent colds and flus, and sometimes bleeding gums from brushing a little bit too hard. We then look at deficiency versus therapeutic prescribing in that as well. By combining all this information, we can put out a good action plan for this patient. I'm then thinking, is it a single nutrient or multiple nutrients required? And that's where that table comes in handy greatly, because I can look at the endpoint numbers and say, what's driving this person's health? What is their main nutritional deficiency? What is their main state of being? What can we do today to make the biggest difference nutritionally sound? And again, like I said, I use food as medicine and support this with herbal medicine, tea and teas as well. I use a lot of teas in clinic. I'm also thinking activated versus, I'll call them not activated vitamins. So for example, in MTHFR, as mentioned earlier, those patients don't metabolize folic acid effectively. So do I make the decision to look at folinic acid or 5-MTHF particularly for that person? Or do I look primarily at diet, B12, B6, other cofactors such as zinc and magnesium, inositol and choline as well. So there's a wide range of different nutrients I'll be looking at that's specifically going to enhance the primary driver. It may be another health condition. So I might be thinking of, again, pyrrole disorder, where the people do not metabolize B6 and zinc effectively. There's a certain molecule, that's just called HPL, that combines and binds up the zinc and B6 in the patient, blocks receptor sites and increases it in larger amounts in the urine, rendering them consistently vitamin B6 and zinc deficient. Do I use the activated form of B6 in these patients, or do I use the standard form in combination with zinc? I use it with food. And do I use other cofactors such as coenzyme Q10, magnesium, omega-3, may even look at some omega-6 oils as well, depending on what their metabolism with delta-5, delta-6 desaturase is. And when combining all this information, I'm thinking, what is best for this person? That's where I go, looking at the synergy, looking at the drivers, looking at what's next for this person. And as I said, this is only an introduction to prescribing, so more webinars and seminars will be presented specifically on these topics. Another thing we have to look at is antagonists, things that actually block or reduce the absorption of other nutrients. There are certain misconceptions that are out there about certain minerals. We don't have time to go through that in this session. I'll be covering that at a different time. But you can take a number of minerals together, like calcium and magnesium. However, it's when the dosages are too far apart. For example, 500 milligrams of calcium and 20 milligrams of magnesium, that's when you get inhibition, or the opposite way around. When they're in the correct ratios, you find they'll enhance the absorption of each other. Think of cautions, contraindications. Classic ones are, St. John's wort with some medications. So we have to always keep that in mind. Review everything before you do your final prescribing. Think back, have I covered all the actions and functions in the table that I decided with my clinical thinking? What do I need to do next? Am I going through my phases? Phase 1, correct and identify any nutritional deficiencies. Phase 1, part 2, is thinking about glucose metabolism or insulin resistance, antioxidant capability, anti-inflammatory results. No matter what condition, think of the early phase, phase 1, as foundational and building upon there. And then, like I said in the original, and in the first video, I should say, write it all down or print it up and give it to the patient so the information is clear, so there's no misunderstanding. The information is clear, but it also helps you clear in your mind as well. And one of the main things I want you to remember is clinical prescribing includes the more you practice it. The more you practice, confidence will build. It will build over time. You'll get more confident in yourself and confident in your prescribing. It does take time. So review your notes, go through all your slides, for example, read up on your textbooks. There's a couple in the references that I've got here. And the idea is look at all the information and practice delivering that information. Yeah, when, why, how long, what kind of treatment, place it all together. So I'd like to thank you all for your attention. I wish you all the very best. Thank you for watching part 2 of Clinical and Therapeutic Prescribing. I do wish you all the best. Please, again, for more information, follow me on Instagram and review my website for further details. Thank you, good luck and all the best.